Hello everyone and welcome back to the channel. One of the most emotional conversations I have in clinic isn't actually about arthritis, it's about starting a family. Almost every month I meet women who have recently been diagnosed with rheumatoid arthritis, lupus or another inflammatory condition, and one of the first questions they ask me is, "Doctor, will I still be able to have children?" Sometimes they've already searched online and frightened themselves. They've read about medications causing birth defects, they've seen stories on internet forums, and they're worried that having arthritis means they won't be able to have a healthy pregnancy. The first thing I usually tell them is this: the vast majority of women with inflammatory arthritis can have healthy pregnancies and healthy babies. That statement is incredibly important because it's something many patients don't hear often enough. The key is planning. Pregnancy and rheumatology medications require careful planning, good communication, and close teamwork between you, your rheumatologist, your GP, and your obstetric team. If you get those things right, outcomes are usually excellent. In today's video, I'm going to explain which arthritis medications are considered safe during pregnancy, which medications need to be stopped beforehand, what happens during breastfeeding, why controlling inflammation is actually one of the most important parts of having a healthy pregnancy, and some of the common myths that I hear every week in clinic. One of the biggest misconceptions is that as soon as you become pregnant, you should stop all of your medication. I completely understand why people think that. If you're carrying a baby, your instinct is to avoid taking anything that could potentially cause harm. The problem is that uncontrolled inflammatory arthritis can also cause problems. If somebody has very active rheumatoid arthritis, severe lupus, or active vasculitis, that inflammation doesn't just affect the joints, it affects the whole body. Active disease has been associated with increased risks during pregnancy, including miscarriage, premature delivery, and lower birth weight. In other words, uncontrolled inflammation may actually be more dangerous than continuing the right medication. That's why we always try to achieve good disease control before pregnancy whenever possible. One of my favorite phrases is, the best pregnancy is a planned pregnancy. If you're thinking about having a baby over the next year, don't wait until you've become pregnant before speaking to your rheumatologist. Ideally, we'd like to review your medications several months beforehand. That gives us plenty of time to stop medicines that aren't suitable, introduce safer alternatives if necessary, and make sure your arthritis is well controlled before conception. That planning makes an enormous difference. Now let's talk about individual medications because this is where most of the questions arise. Let's start with methotrexate because it's probably the medication that causes the greatest anxiety. Methotrexate is an excellent treatment for rheumatoid arthritis and many other inflammatory diseases. I've prescribed it thousands of times and it's transformed the lives of many patients. However, methotrexate should not be taken during pregnancy because it can interfere with normal fetal development. If you're planning a pregnancy, methotrexate needs to be stopped beforehand. Your rheumatologist will advise you exactly when to stop it and what alternative treatment should be used while you're trying to conceive. We also usually recommend folic acid supplementation. One message I'd really like people to remember is this: never stop methotrexate on your own without discussing it with your rheumatology team. If you suddenly stop treatment without an alternative plan, your arthritis may flare significantly, and that's exactly what we're trying to avoid. Another medication that needs careful planning is leflunomide. Unlike methotrexate, leflunomide stays in the body for a very long time. In some people, it can remain detectable for many months. That's why we sometimes use a special washout treatment with cholestyramine before pregnancy to remove the drug more quickly. Again, this is something that should always be discussed well in advance with your rheumatologist rather than after you've become pregnant. Mycophenolate is another medication that is not compatible with pregnancy. It's commonly used in lupus and other autoimmune diseases, particularly when the kidneys are affected. Unfortunately, it carries a significant risk of birth defects and must be stopped before conception. Fortunately, there are safer alternatives that can often be used instead, which is another reason why planning is so important. Now let's move on to the reassuring news. Not every rheumatology medication needs to be stopped. In fact, several medications have excellent safety data in pregnancy. One of the safest medications we use is hydroxychloroquine. Many patients with lupus are understandably surprised when I tell them that I actually want them to continue hydroxychloroquine during pregnancy. That's because good evidence shows it helps control disease activity and may actually improve pregnancy outcomes. It's also generally considered compatible with breastfeeding, making it one of the most reassuring medications we prescribe. Sulfasalazine is another medication that is generally considered safe during pregnancy. It's widely used in rheumatoid arthritis and inflammatory arthritis, and many women continue taking it throughout pregnancy. We usually recommend folic acid alongside sulfasalazine because it can interfere slightly with folate metabolism, but overall it's one of the medications we're very comfortable using. Azathioprine is another example. Years ago, there was understandable concern about using azathioprine during pregnancy, but we've now accumulated a great deal of experience, particularly in autoimmune diseases such as lupus. When clinically indicated, azathioprine can often be continued throughout pregnancy under specialist supervision. Patients often ask me about biologic therapies because these medicines sound much newer and more powerful. The reality is that we've learned an enormous amount over the last 20 years. Several anti-TNF medications have reassuring pregnancy safety data, and many women successfully continue biologic therapy during pregnancy depending on their individual circumstances. Some biologic cross the placenta more than others, which means decisions about continuing treatment later in pregnancy need to be individualized. There isn't a single answer that applies to everyone, and that's why these discussions are so important. Perhaps the biologic that receives the most attention in pregnancy is sertolizumab. One reason for that is that very little of the medication crosses the placenta, making it an attractive option for women who require ongoing biologic treatment throughout pregnancy. Again, this is something your rheumatologist will discuss with you based on your disease, your previous treatments, and your overall health. Another question I hear regularly is about steroids. Many patients worry that prednisolone is dangerous in pregnancy because they've heard steroids can have lots of side effects. The truth is rather more balanced. Prednisolone can be extremely useful during pregnancy, particularly if somebody develops a flare. Like every medication, we try to use the lowest effective dose for the shortest possible time, but it remains an important treatment option when needed. Sometimes controlling inflammation quickly is the safest option for both mother and baby. One of the nicest parts of my job is telling patients that many women with rheumatoid arthritis actually feel better during pregnancy. This is something we don't fully understand, but pregnancy changes the immune system in fascinating ways. Around half of women with rheumatoid arthritis notice that their symptoms improve while they're pregnant, sometimes dramatically. Unfortunately, there's another part to that story. After the baby is born, many women experience a flare during the first few months. That's something we actively plan for. Rather than waiting for symptoms to return, we'll often discuss a management plan before delivery so everyone knows what to do if the arthritis becomes active again. Having that plan in place can make those first few months much less stressful. Breastfeeding is another area that generates a huge number of questions. The good news is that many rheumatology medications are compatible with breastfeeding. Hydroxychloroquine, sulfasalazine, azathioprine, and several biologic therapies can often be continued, while prednisolone is also usually compatible, although occasionally timing feeds around higher doses may be recommended. On the other hand, medications such as methotrexate and mycophenolate should not be taken while breastfeeding. Once again, individual advice is essential because recommendations vary according to the medication you're taking. Before I finish, I'd also like to say a few words about fathers because this question comes up surprisingly often. Men frequently ask whether taking arthritis medication will affect their ability to have healthy children. For many rheumatology medications, the evidence is reassuring, but it's still sensible to discuss family planning with your rheumatologist before trying to conceive. That allows any necessary medication changes to be made well in advance and gives both parents confidence moving forward. So if you remember nothing else from today's video, I'd like you to remember these 5 messages. First, most women with inflammatory arthritis can have healthy pregnancies and healthy babies. Second, don't stop your medication without speaking to your rheumatology team. Third, planning your pregnancy is one of the most important things you can do. Fourth, keeping your arthritis under good control is often just as important as choosing the right medication. And finally, every pregnancy is different. The right medication for one patient may not be the right medication for another, which is why personalized advice from your rheumatologist is so important. If you're planning a family and have rheumatoid arthritis, lupus, psoriatic arthritis, ankylosing spondylitis, or another autoimmune condition, I hope this video has reassured you that having a successful pregnancy is absolutely achievable. With modern treatments, careful planning, and close medical support, the outlook has never been better. If you found this video helpful, please like, subscribe, and share it with anyone living with inflammatory arthritis who may be thinking about starting a family. And if you'd like a specialist consultation or pre-pregnancy medication review, you can contact Pure Rheumatology London using the details in the description below. Thank you very much for watching, and I'll see you in the next video.